Welcome to Emergency Medicine Coach. Today we are covering an essential emergency medicine topic, upper gastrointestinal bleeding. We'll go through the ED approach, management, advanced airway strategies like the salad technique, a Viva case, and an advanced SBA question to boost your exam prep. Upper GI bleeding is defined as bleeding proximal to the ligament of Treves. Clinically, it presents as hematemesis, either fresh blood or coffee ground vomit, melena, black tailed stools, and in brisk cases, sometimes hematochezia, which can mimic lower GI bleeding. Upper GI bleeds occur in about 100 per 100,000 adults per year. Mortality ranges between 2 and 15%, and it's especially high in elderly patients or those with comorbid conditions. Key risk factors include liver disease with varices, NSAID or anticoagulant use, and previous GI bleeds or ulcers. The most common cause is peptic ulcer disease, accounting for about 60% of cases. Other notable causes include esophageal and gastric varices, erosive esophagitis, and gastritis, malarious tears, malignancies, and rare causes like duodenal lesions. Your priorities on arrival are the ABCs: airway, breathing, and circulation. Secure two large bore IVs, apply oxygen, attach the cardiac monitor, and assess for hypoperfusion, looking at mental status, blood pressure, and orthostatic vitals. Remember, don't delay resuscitation while sorting out the diagnosis. In massive upper GI bleeds with active hematemesis, airway protection becomes very challenging. The salad technique, suction assisted laryngoscopy, and airway decontamination is a critical method. You insert a rigid suction catheter into the oropharynx before intubation, continuously suctioning during laryngoscopy. You can even park the suction catheter in the esophagus to divert ongoing bleeding. This technique improves visualization and helps prevent aspiration during intubation. It's an essential skill to master in the crashing GI bleed. Resuscitate with balanced crystalloids if hypotensive. Transfuse packed red cells if the hemoglobin is below 7 or below 9 in cardiac patients. Also, correct coagulopathies. Reverse INR if above 1.5 and give platelets if they are below 50,000. For massive bleeds, activate your massive transfusion protocol early. The Glasgow Blatchford score or GBS helps predict the need for intervention. A GBS 0 suggests safe outpatient management, while a score of 1 or higher warrants admission for further care. After endoscopy, the Rockall score can help assess the risk of mortality or rebleeding. For non-variceal bleeds, start an IV proton pump inhibitor like pantoprazole 80 mg bolus followed by an 8 mg per hour infusion. If you suspect a variceal bleed, especially in cirrhotic patients, add octreotide infusion and ceftriaxone 1 gram IV daily to reduce bacterial translocation and improve outcomes. Endoscopy is the gold standard for diagnosis and treatment. Most patients need it within 24 hours, but those with suspected variceal bleeding or hemodynamical instability should get it within 12 hours. Endoscopic interventions include banding, clipping, injection therapy, or cautery. If the bleeding persists despite initial endoscopy, you should consider repeat endoscopy, angiographic embolization, or if all else fails, surgical intervention. In massive variceal bleeds, a Sengstaken Blakemore balloon can be used temporarily as a bridge to definitive therapy, but it carries significant risk. Patients can be safely discharged if they have a GBS of 0, no active bleeding, and reliable outpatient follow up. For everyone else, including those with higher GBS scores, ongoing bleeding or suspected varices should be admitted and managed in coordination with gastroenterology. Let's summarize. Prioritize ABCs, early resuscitation, and airway control, including using salad in massive bleeds. Use GBS for a stratification. For non-varicose bleeding, start PPI and octreotide and antibiotics for suspected varicose bleeding. Ensure timely endoscopy, ideally within 12 to 24 hours. Involve GI early for all admitted patients. Let's test your applied knowledge with a clinical viva scenario. A 62-year-old male with alcoholic liver cirrhosis, hypertension, and previous esophageal varicose banding presents after 6 hours of hematemesis and melena. On arrival, he is hypotensive at 85 by 50, tachycardic at 120, pale and confused. What are your immediate priorities on arrival? What resuscitation targets should you aim for? What are the recommended blood transfusion thresholds? What pharmacologic therapies should you start? What's the role of PPIs before endoscopy? When should you involve gastroenterology? How do you restratify this patient? When should you consider intubation before endoscopy? If endoscopy fails, what are your next options? Now, let's finish with an advanced single best answer question. A 55-year-old male with non alcoholic cirrhosis present with large volume hematemesis. Blood pressure 88 by 60, heart rate 125, saturation 93% on oxygen. Is pale, cool, GCS 14, labs show hemoglobin 6.5, platelets 45,000, INR 2.1. He has already received 1 liter of crystalloid and 2 units of packed red cells but remains hypotensive. What is the most appropriate next step in management? Insert a nasogastric tube, administer tranexamic acid, start pantoprazole infusion and await GI consult, start octreotide, antibiotics and prepare for urgent endoscopy, refer directly for surgical intervention. The best answer is D. Initiate octreotide infusion, administer antibiotics, and prepare for urgent endoscopy. This prioritizes the varicose bleeding protocol. NG tubes are not routinely needed. TXA hasn't shown benefit per the halted trial, and surgery is reserved for cases where endoscopy and IR fail. Thank you for watching Emergency Medicine Coach. If you found this video helpful, please like, subscribe, and comment below with your toughest GI bleed cases or your favorite airway tricks. Stay tuned for more high-yield emergency medicine content, and I'll see you next time.